In this video, we're going to talk about caring for muscle and bone injuries. Viewer discretion is advised. Some slides may have visual effects that aren't always suitable for all audiences. We use the Emergency Medical Responder First on Scene for our Emergency Medical Responder course. We do not get paid to use this book. However, over the years, this course has been the easiest for our students to comprehend. Therefore is why we utilize it. This work is protected by the United States copyright laws and is provided solely for the use of our instructors to teach courses and assess the student learning process. The content on this website has been made available for our instructors to copy and distribute to students in our classes as we see necessary. All education provided is a guideline to help you learn new concepts to better treat your patients. Your local protocol supersedes any education you learned in this course. You must also always review with your medical director before changing your treatment plans that are outside of your local protocols. We will define the following terms: the anatomical position, angulated, blunt force trauma, closed fracture, cravat, dislocation, fracture, manual stabilization. Manual stabilization, open fracture, position of function, sling, splint, sprain, strain, swath. You will be able to describe the components that make up the musculoskeletal system, identify the major bones of the skeletal system, explain the functions of the musculoskeletal system, and differentiate between the direct and indirect forces and the injuries they cause. You'll be able to differentiate between an open and closed skeletal injury, between a strain, sprain, fracture, and dislocation, describe the signs and symptoms of a musculoskeletal injury, and explain the importance of an appropriate assessment of the distal extremity. You will be able to explain the appropriate care for a patient with a musculoskeletal injury, explain the priority of care for a patient with a suspected open skeletal injury, explain the purpose and methods for manual stabilization of a skeletal injury, and explain the criteria for placing an angulated extremity into an anatomical position. You'll be able to explain the priority of care for a patient with a multi-system trauma, demonstrate the appropriate assessment of a skeletal injury, demonstrate the appropriate care for a patient with a long bone injury, and demonstrate the appropriate care for a patient with a joint injury. You'll be able to demonstrate the proper technique for manual stabilization of a skeletal injury, demonstrate the proper placement of an angulated extremity injury into an anatomical position, demonstrate the proper placement of an arm in a sling, demonstrate the ability to place the hand, foot in the position of a function during immobilization of the extremity, and value the importance of proper body substance isolation precautions when caring for a patient with musculoskeletal injuries. In this section, we're going to talk about the musculoskeletal system. The musculoskeletal system consists of muscles, bones, joints, connective tissue, blood vessels, and nerves. The four major functions are support, movement, protection, and cell reproduction. Here's the anatomy of the extremities. So A equals artery, N equals nerve, and V equals vein. The skeletal system consists of the bones and joints of the body. Its two major divisions are the axial skeleton and the appendicular skeleton. All the bones that form the upright axis of the body, including the skull, spinal column, sternum, which is the breastbone, and the ribs, make up the axial skeleton. The appendicular skeleton is made up of all of the bones that form the upper and lower extremities, including the clavicles, scapula, arms, wrists, hands, hips, legs, ankles, and feet. There are two divisions of the skeletal system, are the appendicular skeleton, which is shown in the first figure in red, and then the axial skeleton, which is shown in the second figure in red. In this section, we're going to talk about the appendicular skeleton. The appendicular skeleton is bones that form the upper and lower extremities. Upper extremities are the shoulder girdle, the arms, and the fingers. Here are your bones of the upper extremities. The lower extremities include the pelvis, the legs, and the toes. Here are the bones of the lower extremities. Causes of extremity injuries can be direct force or indirect force. So with the direct force, they can have external force that directly affects the body to cause injury at the point of impact from a fall or striking of an object, where indirect force is the energy of a force that's transferred up or down the extremity, resulting in injury farther along the extremity. Causes of extremity injuries can be a twisting force, which is where the body remains stationary while the hand or the foot continues to turn. There are three basic types of mechanism of injury. So the indirect force, the direct force, and the severe twisting force. Here's the select mechanisms of extremity injuries. Types of injuries can be closed injuries, which means that there's no break in the skin, or an open laceration to the scalp while the cranium still remains intact. Then there's the open injury, which is a soft tissue adjacent to the injury damage, and it's open. Other types of injuries are full extent of injuries determined through x-ray, and do not try to diagnose that injury because you're not an x-ray machine, so you can't ever say for sure. You don't want the patient to think they have a sprain when really it's a fracture. And you don't want to have that liability taken on you either, so just make sure that you're not diagnosing them or telling them exactly what's wrong with them, because in the end, you don't know at that point. Here's examples of a closed and open fracture of the lower leg. So as you can see with that open fracture, it came through the skin. So a fracture is any time a bone is broken, chipped, cracked, or splintered, and a dislocation is where one end of the bone that is part of a joint is pulled or pushed out of place. The force of the dislocation may cause a fracture of the adjoining bone. A sprain, though tough, its fibrous tissues are called ligaments that hold together the bones that make up the joint. The tendons then attach the muscle to the bone, and then any excessive twisting forces can actually cause the ligaments and tendons to stretch, tear, and possibly resulting in a sprain type of an injury. A strain is caused by overexerting, overworking, overstretching, or tearing of a muscle. A sign common of many serious bone injuries is angulation or deformity. So the angulated injuries occur when an extremity is bent where it normally should be straight. Such injuries may be slight, which means that the vessels and the nerves that serve that extremity will likely still be intact. In those cases, though, you will most likely be able to feel a distal pulse and the patient will have normal sensation, or they'll be able to feel or touch you. And motor function as well, so that's when they're able to move that limb. So if their angulated injuries are extreme, they can actually cause damage to the blood vessels, disrupting that blood flow. So you may not feel a distal pulse, and the patient may experience a change in sensation and or that motor function. So deformed injuries may be also opened or closed, so just keep that in mind. Signs and symptoms can be pain, swelling, discoloration, deformity, inability to move a joint or a limb, numbness or tingling sensation, and loss of distal pulses. They can also have slow capillary refill, grating or crepitus, sound of breaking at time of the injury, and an exposed bone. You want to assess the injuries for adequate circulation, sensation, and motor function, or CSM. You want to do this before and after immobilization, so you know if you lose the pulses due to any movement that you may be doing. And then bleeding in the tissues will present as swelling and discoloration. You also want to check for circulation compromise, so if there's no distal pulse, pale or cool, cyanosis, and then capillary refill time is greater than 2 seconds. Here's how assessing for capillary refill works in the fingers. You pinch the fingers, you release, and if the blood comes back within 2 seconds or it turns pink or red, then you know that your cap refill is good. During your emergency care, you're going to do your scene size up, you're going to do your scene safety, your BSI precautions, your PPE, and look to see what the mechanism of injury is. At this point, you're going to consider the need for spinal precaution and then the total number of patients you have to know if you need additional resources. During your primary assessment, you're going to get impression of the environment and the patient, determine if that patient needs to be moved and transported, assess ABCs, assess the mental status, and detect and correct any life-threatening problems. You're going to care for skeletal injuries in the following order. You're going to take care of the spine first, then the skull, then the rib cage, pelvis, thighs, and then extremity injuries that have no distal pulse. You're going to take proper BSI precautions, perform your primary assessment, cut away any clothing to expose the injury site, and control bleeding if there is an open wound. You're going to check for distal circulation, sensation, and motor function in the affected extremity and immobilize the extremity using a manual stabilization or splints. You're going to then apply a cold pack or ice pack to the injury site to help reduce that pain and swelling, administer oxygen per your local protocol, assess the patient's vital signs, and then give them emotional support, which is important when caring for a patient with these musculoskeletal injuries. In this next section, we're going to talk about splinting. Splinting is the process of immobilizing an injury using either a commercial or an improvised device, such as a piece of wood, cardboard, or a folded blanket. Any object that can be used to restrict the movement of the injury is called a splint. During manual stabilization, that is when you're using your hands to restrict movement of an injured person or a body part. Complications associated with extremity injuries can be prevented or decreased with the proper splinting. Here's an example of a manual stabilization of an injured limb. This allows reposition and transfer of a patient while minimizing movement of the injury. Complications resulting from splinting can include pain, damage to the soft tissues, bleeding, restricted blood flow, and closed injuries can become open injuries. The general rules for splinting can be assess and reassure the patient, expose the injury site, control all major bleeding, dress any open wounds, and check for distal circulation, sensation, and motor function before and after splinting, and then splint the injuries before moving that patient. You always want to be sure, though, that you have your materials ready before splinting and gently realign the angulated limbs without distal circulation to the anatomic position per your local protocol. You want to immobilize the suspected fracture site and joints above and below the injury site with either a sling and swath for the upper extremities or secure lower extremities to each other. You can secure splints with cravats or roller gauze. You want to elevate the extremity and minimize the effects of shock by maintaining body temperature and providing oxygen per your local protocols. When you have to manage angulated injuries, you do only what you have been trained to do and what is allowed in your EMS system. If you have no distal pulses and the skin distal extremity is pale or blue and cold, you need to take action immediately to minimize the potential permanent damage. You do not want to force the limb if you meet resistance or if the patient complains of too much pain. You want to apply a soft splint and elevate the limb by propping it up on a blanket roll or a pillow, and then provide oxygen if allowed or if your local protocol says so. Types of splints for soft splinting can be pillows, blankets, towels, cravats, dressings, triangle bandages, and then sling and swath. So here you're going to place one end of the base of the triangle bandage over the uninjured shoulder and ensure that the top of the triangle is pointed toward the injured arm. You're then going to bring the lower end of the bandage up and over the shoulder on the injured side and then tie a knot at the side of the neck. Then you're going to pin or tape the apex to form a pocket at the elbow. Here you'll see that they pull another cravat around and they'll tie it again right behind the elbow or right behind the shoulder area. Remember, splinting doesn't have to look pretty. It has to be functional and to help control any movement of that patient's arm. Moving on to rigid splints, they can be plastic, metal, wood, or even compressed cardboard. So as far as commercial splints go, they can be made of wood, aluminum, cardboard, foam, wire, and plastic. Inflatable splints or air splints, they are used for patients with injuries to the arm or lower leg bones. Pneumatic anti-shock garment is a special device for splinting suspected pelvic and femur fractures, but you want to be sure that you check your local protocols before using these because they're not highly used everywhere. Improvised splints can maybe be soft or rigid and made from a variety of different materials. The SAM splint here that you see can be configured to immobilize an injured finger, wrist, arm, you name it. The SAM splint can basically be configured to meet whatever needs you may need. Here you have a SAM splint configured to immobilize an injured forearm. Here's the SAM splint configured to immobilize an injured humerus. And here you have the SAM splint configured to immobilize an injured lower leg. In this next section, we're going to talk about the management of specific extremity injuries. So the management of specific extremity injuries starts with applying rigid splints for injuries to the forearm and lower leg. You want to use soft or rigid splints for injuries to the arm, elbow, wrist, or hand, and then use soft splints for injuries to the ankle or the foot. Again, always checking that circulation, sensation, and motor function before and after you move that patient. This is a very important step to not forget. Here's your shoulder splint. So you're going to apply a sling and swath. Ensure that the hand is higher than the elbow and secure the entire arm with the swath. Here is the upper arm immobilized, and it's immobilized with a rigid splint from the shoulder to the elbow, and then applying a sling and swath that will elevate and support that limb. Here you have an elbow that you want bent, and it's secure, short, rigid splints on either side of the arm, and then apply a sling and swath to elevate and support that limb. Here you have an elbow that is straight, so you're going to pad that armpit. The splint should be extended from the armpit beyond the fingertips, and then use that roller bandage to secure that splint to the arm, starting at the distal end, and then secure that arm to the body with cravats. Here is the forearm, wrist, and hand that's splinted. This splint should extend from the elbow to beyond the fingertips and use a sling and swath for the elevation and support. Here's a simple immobilization of the finger. So you're going to use a tongue depressor as a splint or tape the finger to another uninjured finger. Very simple and easy. With upper extremity injuries, you're going to place the hand in a position of comfort, roll of gauze in the patient's hands, and then the finger extend over the splint. Injuries to the shoulder, you're going to knock down shoulder or dropped shoulder. That's the injured shoulder will appear that it is droopy. Then the anterior dislocation is the shoulder joint bulging or protruding under the skin at the front of the shoulder. Then slinging and swathing with padding between the arm and the chest is most beneficial. Here you can see that you got a deformity caused by a dislocation of the shoulder joint there on the left side. Injuries to the upper arm. So the upper end or the proximal end is where the shoulder joint is formed along that midshaft of the bone, and then the lower end or the distal is where the elbow joint is formed. The deformity key sign of this injury is to the bone. This is after controlling bleeding. You want to dress and bandage any open wounds to the injured extremity. You're going to check distal circulation, sensation, and motor function before and after splinting. You're going to select the appropriate size splint for the injury and pad that splint thoroughly. You're going to firmly secure the splint, leaving the fingertips or toes exposed so you can monitor the distal circulation, sensation, and motor function. After immobilization, you're going to then reassess the distal circulation, sensation, and motor function again. Next, you want to elevate that extremity. So for an arm, you can use the sling to immobilize it against the chest, but for a leg, you want to prop it on a pillow or a rolled blanket. This is only indicated if there is no spinal injury. With injuries to the elbow, the joint is formed by the distal end of the humerus and the proximal end of the radius and ulna. You want to immobilize that elbow in position of which it was found. So again, you're going to check that circulation, sensation, and motor function prior to splinting. Secure a rigid splint or splints to the arm, and then apply a sling and a swath. Making sure before you're done, you recheck the circulation, sensation, and motor function. Ensure that the hand is in the position of function. Splinting an injured elbow in a straight position using a cardboard splint is just fine. It works great. For injuries to the forearm, wrist, and hand, its most effective splint is a rigid one. The patient then can be made comfortable with a pillow splint. And if needed, you can wrap a gauze or cravats around so that it's all in place, so the patient doesn't have to worry about it falling. Here's where you're going to manually stabilize the limb prior to splinting it. So you're going to manually stabilize above and below the injury. Again, checking circulation, sensation, and motor function before and after splinting, or any movement really. Then you will apply a rigid splint to that limb. Then you'll place the limb in a sling and recheck that circulation, sensation, and motor function. A pillow makes a great soft splint for wrist and hand injuries. So basically you put the whole thing right inside there and you wrap it up with a pillow and you put cravats or gauze or whatever you have available, you wrap that around it, and anything to immobilize it, but a pillow does work great. With injuries to the fingers, not all injuries require a rigid splint, but you want to immobilize any injured fingers by taping the finger to the adjacent uninjured finger. You can also use a tongue depressor, an aluminum splint, or even a pen or pencil would work just fine. With lower extremity injuries, when the patient has multiple injuries or multi-system trauma, totally immobilize on a long spine board or a scoop stretcher. Be sure that you have proper equipment and sufficient number of rescue personnel on hand to assist though. With pelvic injuries, they can damage the major blood vessels and internal organs. The pelvic girdle injuries may be managed with a long spine board or a scoop stretcher and blankets. The pneumatic anti-shock garments may be considered for immobilization, but again, be sure that you check your local protocols. So with lower extremity injuries, when you're talking about the anterior hip dislocation, it's when the leg from the hip to the foot is rotated outward or laterally or farther than the uninjured side. Then the posterior hip dislocation is when the leg is rotated inward or medially, and the knee is usually bent at that point. So you're going to place the device under the patient at the level of the pelvis. Then you're going to wrap the device over the top and pull until you hear the buckle click. This signifies that the appropriate amount of pressure has been had. And here you can see that the SAM splint is applied to that injured pelvis. Injuries to the femur can be life-threatening even when the injury is closed. Bleeding inside tissues can be severe. Traction splints, you can use these, which are the mechanical devices that allow for the application of constant traction of the injured extremity. However, with a traction splint, they can only be used for a closed injury, not an open femur fracture. When you have a knee injury, you will not be able to tell if the knee is fractured, dislocated, or maybe even both. So do not attempt to reposition or straighten the injured knee. Then you have what's called a boot top injury, which is the transverse fracture of the tibia and or fibula when a skier falls forward off from the ski tips. So again, you're going to assess the distal circulation, sensation, and motor function, and apply rigid splints on either side of the limb. You're going to pad the splints on both sides of that ankle, and then secure the distal ends of the splints. Then you're going to secure the proximal ends of the splints. And then last but not least, again, reassess the distal circulation, sensation, and motor function. You want to provide care for injuries to the lower legs with a rigid or soft splint. Rigid splints are used for injuries to the ankle or foot, where soft splints are more comfortable for that patient. So it's up to them depending on how injured or how painful it is. And then immobilize in the position found. Here you can see that they're immobilizing of a lower leg using a towel, which works just fine. Again, assessing circulation, sensation, and motor function prior to splinting the extremity. You can choose a splint that extends from the heel to well above the knee. Then secure the splint above and below the knee and at the ankle. Then reassess the circulation, sensation, and motor function after that splint is secured. In this section, we're going to talk about the summary of everything that we just learned. The musculoskeletal system has muscles, bones, joints, connective tissue, blood vessels, and nerves. The primary function of the musculoskeletal system is to support movement, protection, and cell production. In the skeletal system, the bones of the axial skeleton is the skull, spine, ribs, and sternum. The appendicular skeleton is the upper and lower extremities. Signs and symptoms of musculoskeletal injury is pain, swelling, discoloration, and deformity. A strain is stretching or tearing of the muscle. A sprain is a partial or complete tearing of the ligament, and a fracture is cracking or breaking of a bone. Dislocation is the end of a bone that is pulled partially or completely away from the joint. Open skeletal injury is the broken bone end or bone fragments that tear through the skin. And care includes assessment and monitoring the patient's ABCs and appropriate immobilization of the injury. It is critical to assess circulation, sensation, and motor function of extremities distal to the injury to determine if blood vessels or nerves may have been damaged. Direct force is an injury at point where it impacts the body. Indirect force injury is energy that is transmitted from point of contact to a different area of the body where it causes injury. If injured extremity is angulated, it should be splinted in place. If there is no distal circulation, the limb can be placed back into the correct anatomical position with ease and without causing pain for the patient. Skeletal injuries should be stabilized to prevent them from worsening, such as a closed fracture becoming an open fracture. The open skeletal injury, you begin with the primary assessment, expose the injury site, control the excessive bleeding, administer oxygen if allowed, and monitor the patient's vital signs until transport. You need to care for the multi-system trauma patient by assessing and monitoring the ABCs. Assume and care for a spine injury, control any severe bleeding, treat for shock, and coordinating rapid transport.